We will be beginning with the lunch symposium. I request our delegates and guests to please pick up their packed lunch boxes and join us for this session. We are now beginning with the lunch symposium. I request all our guests to please pick up their lunch packets and please join us back in the auditorium. Another 1 or 2 minutes.
Hello. Welcome to the lunch session. We have a session on hepatoprotective drugs, and the first talk is on hepatoprotective drugs in the management of cholestasis. And the speaker is Dr. Ajay Jain, Director, Department of Gastroenterology, Shalby Institute of Gastroenterology at Indore. Over to Dr. Jain.
Thank you, chairpersons. Thank you, INASL, for giving me this opportunity. And in next 15 minutes, I'm going to talk about hepatoprotective drugs in the management of cholestasis. And we all know the cholestasis is defined as either a slowing of bile flow from the river or a complete blockage of bile flow from the river. This blockage can be at the level of hepatocytes, cholangiocytes, intrahepatic ductules and ducts, and extrahepatic ducts. Now, what does it mean that when cholestasis happens, it leads to a bile acid getting built up within the hepatocytes, cholangiocytes. And this accumulation ultimately leads to injury, inflammation both within the bile duct cells, cholangiocytes, and hepatocytes. This ultimately leads to damage of the cells, including apoptosis, that is programmed cell death due to the accumulation of bile acids, or necrosis because of the direct injury to the cells. This damage to hepatocytes and cholangiocytes ultimately leads to a cascading phenomena of events leading to inflammation, fibrosis, and if it is chronic, it eventually leads to liver failure. So this is at the cellular level. But at the symptomatic level, because the lipids excrete the cholesterol, it leads to buildup of cholesterol, leading to hypercholesterolemia and xanthomas. Because of this defect in the bile acid secretions, there is an accumulation of bile salts, there is a stagnant bile flow leading to steatorrhea, weight loss, as well as deficiencies of vitamin A, vitamin D, E, and K. These effects are much more pronounced in chronic cholestasis, which is going to be my main thrush for the treatment, like PBC, PSC, and PFIC, as compared to acute cholestasis, which are most of the time self-limiting, and they cure by the treatment of a specific cause. In India, the trends of cholestasis, as shown in this particular study published in 2023, based on a survey of 125 gastroenterologists, about 50% of gastroenterologists sees about 10 to 20% patients of liver disorders with cholestasis. About 1/3 of the gastroenterologists sees drug-induced liver injury patients, having 5 to 10% of these patients due to cholestasis. Another 1/3 of patients with alcoholic liver disease also have 10 to 20% patients have cholestasis at presentation or during the course of the disease. So based on the level of obstruction, we can have intrahepatic cholestasis when the obstruction is at the level of bile canaliculi, or at the level of hepatocytes or intrahepatic bile ducts, or it can be extrahepatic. When extrahepatic is most of the time it's a mechanical obstruction due to stones or tumors. While based on the duration, if the cholestasis is of less than 3 months, some people say 6 months, it is acute cholestasis. But if it is beyond 3 months or 6 months, it is called as chronic cholestasis. What are the causes? Acute cholestasis is caused because of the biliary obstruction, cholangitis, drug-induced liver injury, sepsis, TPN-associated cholestasis, intrahepatic cholestasis of pregnancy, and alcoholic hepatitis. These are all acute cholestasis, but chronic cholestasis are due to PSC, PBC, PFIC, BRIC, drug-induced liver injury, which ultimately leads to vanishing bile duct syndrome. And these are the rare causes, and some of them are the congenital causes, which we see only in pediatric population. So diagnosis of cholestasis is based on simple things, symptoms, mostly the pruritus, clay-colored stool, and ALP more than 1.5, the upper limit of normal, and GGT more than 3 times the upper limit of normal. And obviously, you need the other test to exclude other causes of cholestasis. Once you have diagnosed, then starts the management. And management should address both cause of the cholestasis and consequence of the retained bile acids within the liver and because of the diminished delivery of bile to the gastrointestinal tract. Therapy should also address symptoms, likely most important being pruritus, and they should prevent the consequence of this malabsorption. Sometime, very rarely, these patients of cholestasis can present with portal hypertension even before the development of cirrhosis. So what effects we are looking in the hepatoprotective drugs in this subset of population to treat detoxification, anti-inflammatory properties, antioxidant properties. The drug should be able to protect hepatocyte membrane and other therapeutic effects like elimination of free radicals. They should have anti-steatohepatic activity, anti-fibrotic activity, and they should be able to prevent cirrhosis. And these are the therapeutic targets for cholestatic liver disease. So first target, you should be able to regulate the bile acid metabolism. UDCA is the frontline drug in this. The other drugs are PPAR agonist like fenofibrate, benzofibrate, and FXR agonist like obeticholic acid. The other targets are you reduce the bile acid damage by the newer drugs like NOR-UDCA, cholestyramine. You regulate the immunity, which is especially important in primary biliary cholangitis, where you use steroids. The other targets by regulating the fibrosis, where you have some newer drugs like ANOX 1,4 inhibitor or LOXL inhibitors. In PSC, the other therapeutic target is to regulate the microbiome by giving them antibiotics like vancomycin and metronidazole. I will be concentrating only on the hepatoprotective drugs, that means those which regulate the bile acid metabolism are those which reduce the bile acid absorption from the intestinal tract. UDC being the most important drug and the most commonly used drug. It has 4 properties. It acts via the multiple mechanism because it is hydrophilic, it is cytoprotective, it is anti-inflammatory, and it is immune modulatory. Being hydrophilic bile acid, it alters the ratio of hydrophilic to hydrophobic components. It promotes the secretion of endogenous bile acids such as chenodeoxycholic acid and lithocholic acid. In clinical practice, it improves biochemical indices and histological progression and improves survival without transplantation. So with more than one of these mechanisms, it leads to protection of injured cholangiocytes against toxic effects of bile acid. It stimulates the impaired biliary secretion, thereby improves the absorption of the fat-soluble vitamins from the intestine. It stimulates the detoxification of hydrophobic bile acid, which are dangerous, and it inhibits the apoptosis of hepatocytes. So it is an effective hepatoprotective agent, and dose is 10 to 15 milligram per kilogram per day, but this dose can be increased right up to 20 to 25 milligram per kilogram per day, especially in patients who have cholestasis with cystic fibrosis. In this particular trial, they looked at the transplant-free survival in patient with PBC at the end of 10 years and 15 years, and they found that those people who were treated with UDCA had significantly higher transplant-free survival as compared to those who have untreated. At the end, it was 66% versus 32%, and at the end of 10 years, it was 78% versus 59%. These are the recommendations about UDCA. UDCA in a dose of 13 to 15 milligram is recommended for all patients of PBC with abnormal liver enzymes, regardless of their histological stage. Biochemical response of UDCA should not be measured at the end of 1, 2, or 3 months. It should be measured at the end of 12 months. INASL recommends UDCA as the first-line pharmacotherapy for all patients with PBC, and it should be continued for life. INASL also suggests that in case a post-transplant PBC recurrence, UDCA is a good drug, an effective drug to improve the liver biochemistry. The next important hepatoprotective drug is obeticholic acid, and this is a FXR agonist, which is abundantly present in tissues involved in the enterohepatic circulation. And by activating the FXR, you modulate the bile acid synthesis, bile acid absorption, bile acid transport, and secretion with a net effect of choleresis, which ultimately helps in improving the cholestasis. In this particular trial, when obeticholic acid was used along with UDCA versus without obeticholic acid, and they found that obeticholic acid in a dose of 10 milligram was significantly better as compared to placebo. However, because of the significant side effects of obeticholic acid, there is a boxed warning from the FDA. Another drug which is hepatoprotective is benzofibrate, and this works primarily by activating the PPAR alpha, which again enhances the secretion of 5-phospholipids into bile. This mechanism reduces the toxicity of bile acids on biliary epithelial cells, and it also inhibits bile acid synthesis, and thereby it helps in cholestasis. This particular trial, where benzofibrate was used in primary biliary cholangitis along with UDCA versus UDCA with placebo, and they found that treatment with benzofibrate in addition to UDCA resulted in significantly better biochemical response, which is higher than the placebo and UDCA therapy. Is UDCA useful in PSC? It has been studied in almost major trials. The UDCA have been used for PSC, but all these trials have shown a biochemical improvement of cholestatic liver enzyme. But there has been no benefit of UDCA in survival or liver injury. A recent systematic review and meta-analysis of 8 randomized controlled trials failed to show a significant difference in mortality, pruritus, fatigue, cholangiocarcinoma, and histology stage progression among patients with PSC. This is a new drug which is NOR-UDCA. It's an homologue of UDCA. It is an artificially synthesized bile acid with a shorter side chain structure than UDCA. And compared to UDCA, it is less susceptible to conjugation by taurine and glycine, and therefore it is easily reabsorbed from the bile duct cells after being discharged into bile, and therefore it changes the composition more toward the hydrophilic as compared to hydrophobic. In a randomized controlled trial in patient with PSC, NOR-UDCA significantly reduced the serum ALP level compared to placebo group. The use of NOR-UDCA in patient with PSC is promising, and there is a phase 3 trial which is undergoing at this point of time. Another important cholestatic liver injury is because of the drug. This particular study by Indian Network of Drug-Induced Liver Injury identified more than 40% patients of drug-induced liver injury present with cholestatic liver injury. Again, if these drug-induced liver injury leads to liver failure, acute liver failure, then N-acetylcysteine and corticosteroid. But if it is chronic cholestatic liver disease, UDCA is an important drug. And these particular trials looked at the antimicrobial drugs leading to cholestasis. The UDCA was found useful. Anticonvulsants leading to cholestasis, UDCA was again found useful. In chemotherapy leading to cholestasis, UDCA was found to be useful. So in all drug-induced cholestasis, if it is not an acute cholestasis, if it's chronic cholestasis without liver failure, UDCA have been found useful to reduce the liver enzymes and improve the survival. Some of them are newer hepatoprotective drugs. The one is odevixibat. This is an ileal bile acid transport inhibitor. It reduces bile acid reabsorption from terminal ileum, thereby decreasing the bile acid levels in the body. The next drug is maralixibat, which is again an ileal bile acid transport inhibitor. It has been approved for the treatment of PFIC, and it helps reducing pruritus by interrupting the enterohepatic circulation of bile acid. We should never forget, while treating with hepatoprotective drugs, the drugs which we should use for control of pruritus, and this is in the line. The first drug should be cholestyramine. The second drug If cholestyramine is not working, it is rifampicin. The third is naltrexone, and fourth is sertraline. And sertraline should be the drug at the end, which is in the dose of 50 milligram per day, and you can increase the dose up to 100 milligram per day after a few weeks if necessary. So, ladies and gentlemen, to summarize, cholestatic liver disease such as PSC, PBC, PFIC, and IgG4 related cholangitis are now being recognized more commonly and more easily, and they contribute significantly to liver disease burden. Updated EASL and ASLD guideline emphasize early identification, risk stratification, and individualized therapy based on biochemical response and fibrosis status, especially in patients with PBC and PSC. UDC remains the cornerstone for the treatment of cholestasis, but agents like obeticholic acid, benzofibrate, nor-UDCA, and emerging drugs like odevixibat and maralixibat are used based on the response. Obeticholic acid response is good, but in advanced cirrhosis, one should be very careful due to safety concern. Newer agents like agents modulating FXR, PPR, FGF19 pathways show promise in reducing cholestasis and fibrosis, and drugs like linerixibat, saroglitazar are under investigation. Thank you so much for your patient hearing.
Thank you, Dr. Jain. Please be seated. We'll have the questions at the end of the sessions.
Thank you. The questions will take combined later. So now it's my pleasure to invite Dr. Mohan Prasad, who will be talking on role of hepatoprotective agents in fatty liver diseases.
Somebody can help with the slides, please. Oh, yeah. Respected chairpersons, and at the outset, let me just thank the organizers of INASL for giving me this platform to deliver this talk on hepatoprotectives. Thanks to Abbott for sponsoring this symposium. So, what are the molecular mechanisms of liver injury that happen in MASLD? This has to be known if you want to know what you want to protect in the liver. First of all is the lipotoxicity, because it's a lipid that is the villain. It just starts accumulating and then triggers cell stress, apoptosis, inflammation, which leads on to a lot of cascade of events. Mitochondrial dysfunction and oxidative stress with impaired beta oxidation that leads to reactive oxygen species generation, damaging DNA, proteins, membranes of the hepatocytes, producing a breakdown in the whole machinery. And then super added is the insulin resistance, which is the key driving force, and the hyperinsulinemia, which leads to de novo lipogenesis, reduces fatty acid oxidation and excretion. So it leads to fat accumulation, leading on to inflammation. And activation of inflammatory pathways is important. Kupffer cells are very, very important macrophages in the liver, which play a role in MASH. So they get triggered, and then they start releasing inflammatory cytokines like TNF-alpha, interleukin-1 beta, interleukin-6, and all those pro-inflammatory cytokines. Also, they just attract all the leukocytes to come to the site and wage a war. So these Kupffer cells also stimulate the Ito cells or the stellate cells which are sleeping, and then make them get converted to myofibroblasts and start laying down collagen. All this is because of the Kupffer cell. They initiate all the problems in the MASH hepatitis. So all this is also has to be stopped. And then the fibrogenesis via the stellate cell activation has to be stopped. These are all the problems that you see: lipotoxicity, mitochondrial dysfunction, insulin resistance, activation of inflammatory pathways, and fibrogenesis. Right. So what are the treatment goals? We have to reverse or slow down the disease progression. We have to improve the patient outcomes. So we have to resolve steatosis, steatohepatitis, fibrosis, and we need to prevent this guy from progressing to an end-stage liver disease. So we have to slow down the process and address the clinical implications of extrahepatic tissues, and also enhancing the quality of life of the patient. So what do we have? Do we have anything at all? Just look at EASL. What does EASL say 2024? If there is F0 to F3 fibrosis, They say if locally approved, resmetirom can be used. Where? F2, F3. There's nothing for F0, F1, nothing. And then it says if it goes to F4, cirrhosis, take the patient for transplantation. This is what the INASL says. And if there is a comorbid condition like type 2 diabetes, then you can use those semaglutide, tirzepatide, the GLP-1 RA plus GIP, SGLT2 like EMPA, DAPA, glyphosine, metformin. And if there is cirrhosis, go for insulin. If there is dyslipidemia, it's all statins. And if it is obesity, again, this, like GLP-1 RA, GIP. And then, of course, bariatric procedures like what we do in BGM, we do a endoscopic sleeve gastroplasty. And if morbidly obese, then laparoscopic sleeve gastrectomy. So, these are the therapeutic armamentarium that we have in MASLD today in the world and even in India. And if you look at the prevalence and incidence of MASLD, we had a whole day session yesterday showing how increasing the MASLD is happening all over globally and also in India. So we have 9 to 53% noted in general population. And if you see this study, it says 52.8% of diabetes patients have, fatty liver disease. And again, there's a beautiful study by Shashank Joshi and Mohan Viswanathan group, 105 diabetology endocrine clinics across the country, 13,750 people enrolled, and they found that MASLD was 68%. In India, North India, 73% had, the highest number of fatty liver disease. Severe fibrosis is noted in Kerala in 20% of people on day one when they visited these guys. So do we have any drugs to answer all this problem? Because it's like exploding like a bubble, in India, and we don't have anything. So what are the unmet needs in pharmacotherapy of MASLD in 2025? There is a lack of approved pharmacotherapy. No globally approved pharmacologic treatment for MASLD even in 2025, ladies and gentlemen. Resmetirom shows promise in phase 3 trials, but not yet widely approved for, and also may not be affordable at $50,000 annual treatment cost. But I'm sure you're going to get it in India at an affordable price. Lifestyle modification, yes, but long-term adherence is poor. So we need there is a need because of this for hepatoprotectives. So do we need hepatoprotectives? A lot of people, how many of you believe you need hepatoprotectives? Please put up your hands quickly. Okay, very few. Yeah, so do we need hepatoprotectives at all? Where is the evidence? Oh no, they don't work. And it's money down the drain. This is guys who speak against them. And guys who speak for, do we have anything better? We don't. And looks like there are studies which I'm going to share with you, and possibly they do some good, and also they do some damage control in the liver. All the molecular mechanisms that I showed you probably will respond. So this was Muhammad Ali, the big guy, so who called the opponent Ali. So now this is a very meek, tiny tot who is just fighting Muhammad Ali. Who's going to win? Let us see at the end. Okay, so there is a need. If there is nothing available, then try alternatives. This is a Rolls Royce which you and I would probably want to own, but we do not have. Then at least a Mahindra SUV which is fully loaded probably will give you all the comforts which the other car will give. So what do they do, the hepatoprotectives? I told you fat accumulation is a hallmark of metabolic MASLD and causes oxidative stress and inflammation. Hepatoprotective agents have been reported to balance lipid metabolism, lipogenesis, lipolysis, lipophagy in MASLD patients. They can also attenuate inflammation and oxidant stress. And they constitute several mechanisms. The constituents of these agents have several mechanisms by which they are actively involved in liver protection. And so these are substances that protect the liver cells against damage, antioxidant action, anti-inflammatory, anti-fibrotic, membrane stabilization, and mitochondrial protection. So these hepatoprotectives are naturally occurring products with a wide range of bioactive compounds in them that have significant hepatoprotective effects, such as silymarin, vitamin E, essential phospholipids, omega-3 fatty acid, glutathione, and bile acid, UDCA. So let us look at UDCA. The ursodeoxycholic acid has been with us for beyond more than 50 years, and we've been using, all of us in real life scenario, we keep using it. So, and this hepatoprotective, anti-apoptotic, and anti-inflammatory, immune modulatory, and antioxidant, and these are all some of the mechanisms of UDCA maintains a dynamic communication between the host and the gut microbiome. It also attenuates a pro-inflammatory response of Kupffer cells. I told that Kupffer cells are the main trigger, and that is attenuated by UDCA. UDCA also directly or indirectly influences TGR5 and FXR. My previous speaker so beautifully put it across to you. And it reduces inflammatory cytokines and oxidative stress. And significant improvements in AST, ALT, GGT, and ALP levels have been noted with this drug. And now, thanks to CDSCO, we are now doing a national multicenter trial, and which is going to be probably the data will be collated and presented in March. So this is on UDCA and MASH. And Radziu et al. Demonstrated a significant reduction in the ALT level. See the plot, differentiation between a placebo and UDCA. Again, fibrosis also came down. So ALT significantly reduced in 28% and normalized in 24%, which means about 52% of guys taking this drug. So within 4 weeks, you can see the ALT-AST response with UDCA in all the trials. Invariably, that has been shown. Meta-analysis Zhang et al. Also shows the same effect, and this is favoring the investigational product, and it reduces ALT and gamma glutamyl transpeptidase, so reduces necroinflammation in the liver by its unique properties. Now we'll move on to another molecule called essential phospholipids. All our cell membranes are made of this biphospholipid layer. Phosphatidylcholine and phosphatidylethanol are important constituents, and phospholipids are the major building block. And phosphatidylcholine is the most abundant constituent of cell membranes. And these, because of their property, once you give it orally, it gets substituted in the breaking down hepatocyte membranes. So it's antioxidant, anti-inflammatory, anti-fibrotic, apoptosis modulating, regenerative, membrane repairing, and lipid regulating effects of EPL have been well documented. In this paper, which was published a decade ago, myself along with Gunderman, we had reviewed the role of essential phospholipids in all different disorders, NAFLD, AFLD, and then, in drug-induced liver injury and the viral. And here I'm just showing you only 16 studies, which we quoted 10 years ago in this article published in the Clinical and Experimental Gastroenterology Journal 2016. 16 trials, all of them showing a positive beneficial response of UDCA, essential phospholipids in fatty liver disease. So this is a new meta-analysis which came in 2020, which again showed not only the ALT, TGL, and total cholesterol, but even the quality of life improved in patients who are put on EPL. So moving on to vitamin E, how many of you know that vitamin E is not FDA approved? It is not FDA approved, it is not DCG approved. Aren't we using it still? We are using vitamin E because nothing else we have in our therapeutic armamentarium in these guys. So vitamin E managing MASLD, results of meta-analysis. Here it shows that ALT comes down and AST also comes down. That has been shown in all the trials in meta-analysis. Again, this also shows that steatosis, steatohepatitis, and the fibrosis, all of them show a positive trend of resolution in the vitamin E arm when compared to the placebo arm. So silymarin, milk thistle, doesn't have a role in MASLD, no significant effect. And again, combination of silymarin, vitamin E, and essential phospholipid was tried, published in 2025, 200 patients. But you see here, there is an improvement in ALT, AST, and GGT. But what is interesting is the BMI dropped by 2 points. So naturally, there will be, once you reduce weight, you tend to reduce your necroinflammation in the liver. So I would take this study with a pinch of salt, because if the BMI did not change, then it's more meaningful. SAMI, of course, is a good drug, and it goes through methylation, transsulfuration pathways, is a methyl donor, and also is contributed to the glutathione, which is the life giver in each cell. So, and it has been, there have been few trials but all in animal studies, and there is no human studies in MASLD with SAMI, so may not be the right choice here. So omega-3 polyunsaturated fatty acids, 20 RCTs, 1,615 participants, and see here it again favors the omega-3 fatty acids, and except for in 2 trials which did not favor the IP. So 15 clinical studies, 14 RCTs, I mean, showing a positive beneficial response. So Muhammad Ali, my friends, let the young guy win against him because he was his fan in 1963. This is recorded in history. So even meek fellows can win. You don't need to wait for somebody who is very strong. I mean, lovely to have, but do we have? No. So MASLD is ever on the rise. Lifestyle modification and weight loss are the cornerstones. And you have Woodca, essential phospholipids, vitamin E, omega-3 polyunsaturated fatty acids, and SAMI are some of the promising hepatoprotective agents until newer molecules are available to target all the pathways of liver injury, which I showed initially, right from steatosis to steatohepatitis to fibrosis stage. Until we get new molecules, these hepatoprotectives will have a role to play. And now I want all of you to put up how many of you are using at least 1 or 2 of the molecules that I showed in this list. Please put up your hands. Be honest. Please put up your hands. Thank you so much. I think that shows that majority are using these drugs in real life scenario. I thank INASL and Abbott for giving me this platform. Thank you so much once again.
Okay, thank you, Mohan, for educating us on the hepatoprotection in MASL. I would like to thank the organizing committee for inviting me to and giving me the opportunity to learn so much of hepatology in last 1.5 days. But before I ask the audience to ask the question, let me first ask one question to both the panelists. What do we mean by hepatoprotection? Just, I'm not very sure that what is the meaning of hepatoprotection. Can anybody emphasize on hepatoprotection?
Okay, so Dr. VGM also showed in his slides, and I also, that in cholestasis, whenever there is a bile acid accumulation, the major impact is on the hepatocyte membrane and on the cholangiocyte membrane. This leads to apoptosis, cell death. So cell death is either because of apoptosis or because of the direct injury. So when we say hepatoprotective drugs, can we protect these cholangiocytes and hepatocyte against the accumulation of bile acid? Because we do not have a treatment for the basic cause of PSC and PBC and PFIC at this point of time. So what we are trying with hepatoprotective drug is the protecting the liver cells against the ill effects of accumulated bile acids in the due course till the time we have. And the studies have shown that you can increase the transplant-free survival in these patients. You can relieve their symptoms. So this is what I mean by hepatoprotective drugs.
Thank you. Now
Sir,
it is open
can
for
I-
any.
Can I add on?
Yeah, sure.
To me, hepatoprotection, adding to whatever my colleague said, Ajay said, is reducing the necroinflammation. Because just the bland fat, the steatosis, even 20 years, less than 5% progress to steatohepatitis and fibrosis, cirrhosis, hepatocellular carcinoma. Whereas on the other hand, if somebody has NASH or MASH, 25% will progress further very quickly. So which means it is the necroinflammation, breaking down hepatocytes, releasing all the alarms, substances which trigger the Kupffer cells, and then also which trigger the Ito cells, which leads to the whole warfare. So if we can prevent the necroinflammation in the liver, I'm sure this will ameliorate. To me, a hepatoprotective agent is one which will reduce the necroinflammation in the liver.
But we also learned that the mechanism of hepatocyte death is apoptosis. So apoptosis also causes hepatocyte death without causing necrosis. So that's why I'm saying these terminologies are not very clear to me. That's why I wanted to
No,
ask.
even an apoptotic cell will send distress signals out. and which will trigger the Kupffer cells.
Okay. Now, the subject is open for question. Please, anybody has any queries? They will be clarifying it. Yeah.
So, while
Professor
Dr. Kar is
Premasiskar.
coming, I'll just ask you a quick question, Doctor. Intrahepatic cholestasis of pregnancy is generally one of the most challenging times because fetus and mother, you both want to look after. UDC alone not working, you try to add more. So, what will be your recommendation for managing a simple case of intrahepatic cholestasis of pregnancy?
Well, it's one of the most difficult situation when you have an intrahepatic cholestasis of pregnancy, especially when they have severe pruritus and they are in their 32nd or 33rd weeks of pregnancy. So other than UDCA, the people, these are all anecdotal reports, and some of the people have tried the biliary drainage by putting a nasobiliary drain in these patients. Some of the drugs which are now being used for PFIC, Odevixibat and Mirilixibat, are being tried in these patients. The drug which is very useful could have been obeticholic acid, but again, because of its significant side effect, it has not been used, tried, or tested. So at this point of time, either you induce a delivery or you use UDCA pull on, or some of the patients have shown response on steroids. So you can use steroids, and gynecologist and obstetrician use steroid for the maturity of the baby. So that can also be tried along with UDCA. But at the end of the day, you do not have any specific drug which can ameliorate their cholestatic symptoms during that pregnancy.
I think, this regarding the intrahepatic cholestasis of pregnancy, I think apart from using the UDCA, a combination therapy of UDCA and adimethionine, the other one which is commercially available as Heptrol, has been also found to be very helpful. My question is to Dr. Ajay. You have shown that this UDCA is helpful in drug-induced, liver injury with the antitubercular drugs. My question is, about few years back, we had put up a small poster where we had tried to select high-risk groups on antitubercular drugs and administered them UDCA on a routine basis versus a placebo group. And we found that none of the patients who were on this UDCA therapy in the high-risk group who received ATT developed jaundice or every evidence of hepatocellular injury. This poster was picked up by Dr. I forgot, somebody from the poster, they picked up the poster for discussion. So, I wanted to know whether there is any long-term study in the literature which says, because of the multifactorial action of UDCA, whether it can protect in patients who are on ATT against hepatocellular injury when given prophylactically, since it is a safe drug.
To my knowledge, there are no long-term or large number of studies with large population where the UDCA have been used as a preventive drug.
Yeah.
But certainly the recent literature suggests that the UDCA, while changing the enterohepatic circulation, changing the ratio of hydrophilic and hydrophobic acid, there is a significant impact of UDCA on the microbiome also. And probably this significant effect of microbiome, it's a complex thing which we still do not understand, probably plays a significant role in hepatoprotection. But again, for the prevention, except few anecdotal studies, there are no good data to support it.
Yeah, because I remember this particular small observational study was picked up by Dr. Abraham Koshi for the discussion. So that's why I wanted to know, because of the, of course, I've never come across long-term studies about it.
In areas of our country with the viral hepatitis still prevalent, around 10% of these people develop severe cholestasis. How do you propose to manage them? I have come across some studies where people use short-term steroids.
Okay. So we have published on this where we picked up all patients of acute viral hepatitis with cholestasis. And obviously, the first line of drug remains the cholestyramine, and which is most of the time ineffective in these patients. So the second line drug is the rifampicin. But what we did in our study, we admitted these patients and we gave them intravenous naltrexone, which is the third line drug for the treatment of cholestasis in acute viral hepatitis. And we showed that there was a significant improvement in cholestasis in these patients, not only in terms of symptoms, their pruritus improved, they had a good quality of life, and their cholestasis improved, and the jaundice improved in due course of time.
I think we have signal from the organizers to wind up the session. Before I wind up, I just want to bring to your notice two occasions where I was called into the court for cases given by patients on chronic liver disease. On two occasions, the judge asked me, I went as an expert, what was the hepatoprotective drug given to this patient to prevent the progression of the drug? They have been given beta blockers, antibiotics, Dufalac, treated efficiently, the usual standard line of treatment. But in the consumer court and the Logayukta, both times I was asked, were these patients given hepatoprotective drugs or any specific drugs to treat liver disease? Actually, the opponent advocate was always arguing that there was nothing given for liver. It's all treatment for antibiotics, for constipation, for this, that, and all those things. Finally, I had to argue a lot, saying that even without these so-called hepatoprotective drugs, we can manage. But I think in such a funny situation, perhaps hepatoprotective drugs of dubious benefits may be of some use. So we can't blame all our colleagues who are using hepatoprotective drugs for all their patients with some sort of liver disease. I think with this, we will end the session. So thank you both speakers for the wonderful session. Thank my co-chairperson and thank the audience for sitting. Even though it's a lunch session, still I would say 40% is full. So thank you audience also for joining the session. Thank you.
Thanks to the chairpersons and the speakers for this lunch symposium. We'll be starting our next session sharp at 2. Thank you, sir.